Next, we'll welcome to the podium Dr. Cecilia Pompili, a thoracic surgeon and researcher from the University of Leeds, United Kingdom. And she's going to speak with us today on where we stand with patient-reported outcomes for early-stage non-small cell lung cancer.
I apologize because I didn't bring my glasses, so it's very hard for me to see that. So I will try to be multitasking here. So, yeah. These are my disclosure, and so because this is a very patient-centered talk, I would start with Jill Feldman's story and stressing the importance of patient perspective in clinical care and also in research. So Jill kindly shared this slide, which is focusing on her thought on how different is the impact and of any treatment and patient's quality of life, and how often we see our patient complaints are not corresponding well to what they are actually experiencing. And you can see here that grade 1 events can impact, especially when they are persistent and, for example, they are impacting on the patient's social and financial, like we heard just now. So tolerable is relative for sure, and tolerable is being able to function for patients. So that's the most important thing. And patients are definitely the only reliable sources of data on quality of life, severity of symptoms, and impact on this daily lifestyle. The only way so to assess these symptoms is directly asking the patient the relevant symptoms and outcomes, as mostly defined nowadays by these measures, and FDA has also released many papers on these. But when we look at the frequency in reporting patient-reported outcomes in oncology, we can see that in lung cancer setting, the probability of inclusion in quality of life among the study endpoints is significantly reduced in the last 5 years. And this is even worse when we are going to consider the availability of quality of life results in the primary publication, with only 40% of quality of life report in the primary publication. So there is definitely an underreporting of patient-reported outcomes in this type of trials. There is also very important to stress that this is in contrast with the increasing amount of guidance, protocols, and recommendations from international society in terms of how to measure the symptoms and these outcomes. So, and the ESMO guidelines recently had released this guidance on implementation of patient-reported outcomes in clinical trials. But when we look also at the ORTC, the European side, we can see that there are also guidances in terms of how to implement patient-reported outcomes in clinical practice. So furthermore, we need also to have a look at the methodology, because increasingly there are efforts to have to develop and various standards, of course, to improve and standardize the collection and reporting and the interpretation of this PRO data. And we try to have a minimally important difference definition, which was not always the case. I'll give you a couple of examples, because this is what we've done with the ELIXR study, which was a study comparing SBRT and VATS lung resection in terms of patient-reported outcomes. And that was a way to use the CPRA graphs in showing the single patient and the plot, and also plotting the subgroup who changed their quality of life during 1 year after treatment. That is also very important when we look at the methodology, because, for example, when we are trying to look at the results, when we look at the VIOLET study comparing minimal invasive and open procedures, and the VIOLET study trial was defining physical function as the primary outcome for at 5 weeks, but he reported statistically significant improvement in the VATS group. But when we look at the minimally, the 5-unit improvement that has been offered as minimally important difference, that was not reached. So you need to have a look also at this PRO's interpretation before making any assumption in this trial. So definitely if CTCAA is the gold standard for adverse event reporting in clinical trials, we need to look at the patient-reported outcomes coverage, because these are not directly accessible by the clinician or even not measurable. Looking at the instrument as well, we have a broader spectrum nowadays in assessing quality of life and other, of course, patient-reported outcomes. Several are still generic, and they allow us to compare to general population. Other ones are more cancer-specific, and of course, lung cancer-specific questionnaire. We worked for almost 5 years to, within the EORTC quality of life lung cancer group, to update the lung cancer specific questionnaire, and that was the first time that surgical specific questions were implemented in a quality of life questionnaire. I think it's also important, to be honest, that nowadays with these multimodality trials and the completely changed landscape for lung cancer, to consider more these customized questionnaires that are created using selected items from libraries. Like we are using, of course, a lot of the EORTC item library that is using validated and translated questions into a big database. But of course, there are also other item libraries that we can use in this setting. So I will go a little bit more in the surgical setting, because this is where my research is coming from, and we try to ask the surgeons a few years ago how many times during their clinical practice and in research they were collecting quality of life data, and as you can see, so less than 50% of them were replying to collect any kind of quality of life data. And in surgical setting, there were already some data underscoring the impact of lung resection on patient quality of life. So, for example, it was very important to identify predictors of potential decline of quality of life after surgery, so that we can identify high-risk patients and support them even before surgery, like we can see now here for extended resection. But also, we use the patient-reported outcomes to underline the importance of some preoperative parameters that are sometimes underscored as the low preoperative DLCO, which was associated with significant decrease on patient-reported outcomes after even minimal invasive thoracic surgery. And other preoperative or perioperative characteristics like age and, for sure, adjuvant chemotherapy. We also use quality of life to understand that patient-reported outcomes may be a better predictor of different recovery trajectory after lung cancer resection. So in these couple of studies, for example, global health status and physical function were identifying patients at higher risk of complication, prolonged length of stay as well, and they were behaving better than traditional objective parameters like you can see here. And then on a further level, the other studies nowadays have stressed in other cancer sites the importance of routinely collecting quality of life data in clinical practice, as they can at least complement other prognostic factors in the pre-surgical decision making. And the role was similar in our cohort of patients using this generic questionnaire. So we use in this study the SF36. So patients with a physical component score more than 50 lived significantly longer than those with a PCS less than 50. And when we try the same approach with a more lung cancer specific questionnaire, you can see that the results were very similar. So to facilitate the implementation in clinical practice, of course, the electronic platform with directly implementation in clinical patients' record will definitely help patients self-report symptoms and toxicity during treatment. We've done this with the ELIXR study. And we were able to demonstrate the different trajectories after lung cancer resection through VATS and SBRT, and the clinicians were directly informed in clinical practice. We try also to have this electronic completion in this randomized control trial performed in China, where the electronic symptoms reporting after lung cancer surgery and the response to alert had an acceptable clinician burden and high clinician acceptability, with a higher level of patient satisfaction indeed. Within the European Society of Thoracic Surgeons, for that reason, we are now testing this quality of life application that is using the RTC questionnaire, more specifically for a surgical question, but definitely it would be a way to implement this kind of outcomes in clinical practice. And I want to come back a little bit more on Jill's story, especially because we always discuss this with her about the tolerability. It should be incorporated in trial design. And so we know that we had already many results in this sense. So the ADURA trial, overall, the data demonstrated that quality of life was maintained with adjuvant osimertinib treatment and no significant differences versus placebo in the SF-36. So it was a generic questionnaire used in this case. But the good thing that even after the 3 years update, the reported analysis revealed that most patients in both treatment groups remained stable or had improvement in the SF-36 physical and mental score. Very good results are being just presented during ASCO with the ALINA results, and that was even more significant because the alectinib demonstrated an improvement in most of the domains by week 12, and followed by maintenance of quality of life results on all the domains up to the week 96. With chemotherapy, sorry, with this slide was taken from the Twitter, but definitely with chemotherapy, quality of life was very low during treatment and then improved only after the chemotherapy period. So had the pleasure to receive Dr. Spicer results from the 816, and of course, 816 demonstrated a consistent quality of life improvement after the expected post-surgical decline in both treatment arms, but needs to be commented because it was the first one reporting the 3 years results. So interestingly, pain and discomfort, as you can see here, symptoms immediately after surgery, which is when we are expecting, of course, the worse quality of life, has been quite lower in the Nivo arm. And when there were not huge difference in the rate of return to baseline quality of life patients between the lobectomy or pneumonectomy or thoracotomy versus minimally invasive. But an interesting postoperative trend favoring Nivo was also showing the higher risk patient of quality of life deterioration as the pneumonectomy patient. So even better results are coming from the 77T because I think that, again, neither treatment arm reached the minimally important difference for any PRO measures, but I think it's very important to show that the percentage of patients where collecting those data was very high, up to 90%. And according to the total score, patients in the Nivo group had a longer time until definitive deterioration in disease-related symptoms that did those with chemotherapy group. So I think that was very important and striking results from the patient's perspective. So we'll skip a little bit on this, and I will go a little bit on how we can make sure that we have a comprehensive PRO's assessment in this sense, so meaningful for the patient. Definitely, we need to assess better the perisurgical period. As you can see here, the surgical assessment was a little bit broader, so we are missing some of the the surgical-related symptoms from the patient perspective. And this is something that we will try to do, like within the RTC, that was a colorectal trial where we are assessing quality of life with different modality during the whole pathway. And this is something that we'll do again with the stage 3 platform, with Dr. Philippe is also involved in. So with a stage assessment of quality of life during all the arms and the control group. Definitely, of course, we will also need to make sure that PROs are part of the decision-making during the cancer progression, and of course, this will be a little bit more complex in the future. That's the reason why the use of PROs in later phase study will not be so precise until even in early phase trials we will implement a correct patient-reported outcomes collection. So as you can see here, this is a very important study just demonstrating the difference between clinician-reported adverse event in early stage compared to in early phase trials compared to the patient's reported symptoms. To conclude this part, I think, again, we are sometimes scared about the burden from our patients in collecting this data. We've done some qualitative studies, and I think our patients so far were reporting that collecting quality of life data in the perioperative setting was clearly facilitating shared decision-making, allowing them to carefully think, but also to discuss with their clinician about possible option. And that was clearly missing when we try to identify the participation of patients in shared decision-making for early stage non-small cell lung cancer. So in both arms, like we heard today, patients were not informed about the possible alternative either way, so surgeons were not citing the SBRT and the other side. So to conclude, I think that PROs in clinical trials and in clinical practice will just, of course, help in systematic toxicity measurement, enhance patient experience and benefit for sure compliance. But on the other side, I think that shared decision-making process should include also patient preferences and priorities. Thank you so much.
Thank you.
And then
So moving along,